and participated in countless webinars since this COVID virus epidemic started in order to educate people about multiple aspects of the COVID disease. And I think it's remarkable the number of hours he's put in on a volunteer basis to help people all over the world to cope with this. And we will now like you, Dr. K.K. Agarwal, to give us an update on the state of vaccine development at this time. Thank you.
Thank you, Dr. Ilana. Thank you, Derek. Thank you, Dr. Patel, Dr. D'Souza, Mary, James, many others who are present here. Thank you for giving me this an opportunity for an important subject. For me, this is 792nd non-stop session in the last 6 months, which I am doing, taking no off even on Sunday, the 2nd of October. The basic aim of this will go to all my member countries. This session, I will also post it to all my doctors in my country. As in the last 1 week, when I talk to most of the doctors, they say they are not aware about basics of vaccine. So I will start from very basics of vaccine, then we come back to the current situation and touching the ethics. So for many of you who are vaccine experts, it may be a revision for you. But most of the doctors in the whole Asia are not aware about the basics of vaccine. They only know vaccine is available. They don't know what type of a vaccine is available. Let me share the screen. Kindly give me the permission.
Yeah, I'll need you a quote.
Has been sold is spike. Why are we taking spike? Because this has the RBM, receptor binding domain. So because of the presence of receptor binding domain, most of the studies are using spike as an antigen, but not membrane, envelope, nucleocapsid. So may need a booster dose, may need several doses. The examples are hepatitis A, flu injection, polio injection, and the rabies. Now, why I am saying is this is the most easily made vaccine is evident from here that 5 of the 3 vaccines which have been approved for limited use till today as a pill that is called AD virus from San Francisco based company, and some people are using a modified Vaccinia Ankara or MVA vaccine as a part of lecture. And then there are different types of phase trials going on. Vaccines by sticking protein into microscopic particle, viral proteins, and adding an adjuvant that stimulates the immune system. You have a RBD, instead of using the spike, are the two companies which are leading the genetic vaccines, the BioNTech plus Pfizer plus China drug maker already have sold millions of doses in anticipation they are going to work. So these are the two vaccines which are taking a lead. Third one is Indian vaccine maker Zydus Cadila, who is working on DNA base. And now these vaccines can be post phase 4 surveillance, even phase 3 trial. They have directly launched in a phase 1, phase 2 trial. Most of the companies are doing phase 1 and phase 2 directly. They are given a clearance for transverse myelitis much earlier than they would have expected. They are not following the side effects with that. And another thing which comes is a human challenge which is happening. And who will get the supply is going to be $1 million question after the vaccine is introduced. Say, for example, India today have said that they will be distributing only 20% of the population will be receiving the vaccine in phase 1. Only 20%. That means 80% of the population may not receive. That is 25 crores is 25 crores is 250 million people will receive this vaccine in the first phase. And Indian population is 6 times that. So these are the ethical issues which I wanted to talk about it. Thank you.
Thank you, Dr. Agarwal. I think you took us from the simple and the basic to the very latest of what is happening in the world. And I think it was quite lucid and well brought out in your familiar style. If I could just put forward a couple of questions that have come in on the chat, sir. Could you take those questions now, please?
Please.
Yeah. One question that we had received earlier was, we keep hearing this word herd immunity being coming up in the media and in a lot of chats, and a lot of people have this doubt. If you could shed some light on herd immunity and where exactly do we stand, or what is the hope of any herd immunity as far as
So the herd immunity concept came, it's an old concept, it's a new one. So we need to understand the word R0 or R0. R0 is the value that number of infections a virus will do to number of people will get infected with 1%. Then we have RT. RT will vary from area to area. That means R0 over time. That means you say RT of New York, RT of Israel 6, which becomes 67%. That means 67% of the community has to be infected before herd immunity comes, either alone or with vaccine. That's one. Number 2 is the model of New York has shown that when 25% of the people get seroprevalence, the first wave will go out, be over. The minimum requirement for the first wave of the infection is 25%, because that's what happened in New York. And with that, we compared it with other countries and we saw the same response. In Delhi, in Mumbai, in Pune, in Indore, Ahmedabad, we saw the same response, that when 25% of the population achieved seroprevalence, the number of new cases, the positivity rate started coming down. So maybe 25% is the first phase, and then it becomes slow. That means first 25% infection seropositivity may be higher, then it slowly grows up. In Delhi, in India, in Delhi, we are now approximately 30%. That means after 20%, it has gone very slow, the positivity rate. You will not be able to achieve a herd immunity by a normal infection per se. You will require the effort of a vaccine. Vaccine plus natural cases will do. The international survey is, the Indian national survey is only 7%. We have many states, we have 25%, but 7%. In other countries, it varies. Somewhere 5%, somewhere 10%. So herd immunity is very, very, very far away. But the question also comes as reinfection. We have documented 4 cases in healthcare workers who got reinfection within 1 month, and they developed a D614G mutation, and they did develop a disease which was severe but not serious. So therefore, reinfection is also a possibility. And we really don't know whether this vaccine will prevent us, 1 vaccine, 2 vaccine, booster vaccine, whether it will prevent the post-vaccine antibody enhancement or not, whether it will prevent the immunogenicity or not, whether this vaccine in children will prevent multi-system inflammatory disease, we don't know. So everything is a big, we don't know at the moment. There are many unknowns which are still unknown, though we know many unknown which are known today.
Thank you. Thank you for that.
Derek, can you ask
yeah.
Dr. Evan to, yeah. Now, you got more questions, Dr. Delang is telling this. Dr. Have you got more questions?
Yes, there was one more question which had come up, in fact, from the YouTube live streaming. And it goes like this. Sir, could you throw some more light on the furin proteases and furin cleavage sites? And how does this impact future research and vaccine development?
When we talk about the spike protein, let me go back to that slide. It will take half a minute. So when you go back to this slide, the second part of it, the bottom two, RBM now when we say, for example, we have why D614 gene mutation is not that deadly because it is making a vaccine. At the moment, I have not read that somebody.
Yes. Thank you. Thank you, sir. And just a clarification again from General Jim James. He just wanted a clarification on the fact that the second dose of the COVID-19, could it be of a different brand or should it be very brand specific? You mentioned that there are vaccines where you could change hepatitis B.
Let me clarify. The India case of 4 cases of reinfection have proved all 4 out of the 4 doctors who developed reinfection, 3 of them did not have antibodies, neutralizing antibodies after the first infection. And with the second infection, within days, they developed the neutralizing antibodies. So you can imagine them as a vaccine, that they received 2 vaccines. First vaccine did not produce an infection, second reinfection was the second vaccine. So that has also proved that second vaccine is required. Now there is a debate. The Russia says 2 vaccines can be different. They are using AD5 and AD26. That means first dose and second dose, they are using the same spike protein, but adenovirus, they are using it differently. So they have opened the hope that why can't you use a different type of a brand the next time? Yes, it is happening in hepatitis B. It is happening in many other conditions where you try to change the brand. That will have to come back from a company to tell us whether it is a brand specific or not. Because most of the companies will say Rabipur in a rabies, they say we are not brand specific. They say you can interchange the brands, but many years they say you don't change the brand. So, this will be a part of debate and manufacturers' instructions. Then only you can say that changing the brand, because when you are changing the brand, you don't know what you are changing, what component of a protein you are changing. Maybe both of them may be using a spike protein, but in nanograms, there may be a difference in nanograms, so there may be a difference in antigenicity.
Right. Dr. Prabha Swaminathan wanted to know, what about MMR? as
There are two
a
vaccines.
solution
There are
for.
indirect vaccines. There are indirect vaccines being on trial. MMR, BCG, both of them are a indirect usage. Like a BCG, you are also using MMR to give you indirect immunity. Now let us understand the concept behind MMR and BCG. When you give a vaccine, it is supposed to produce interferon 1. Interferon 1 is supposed to produce gamma interferon, and gamma interferon is supposed to kill the virus. Therefore, production of interferon 1 will prevent another viral infection for next 3 months. That's what the basis is. But this virus is behaving mischievously. It is not allowing enough interferon to form. Therefore, after COVID-19, you are still prone to get other co-infections. Therefore, if I give a interferon, if I produce enough interferon 1 by giving BCG or MMR, then I may be able to assist the new virus in reducing the complication. That's the assumption. So assumption is before you acquire COVID-19, if you take any other injection, can be flu, can be pneumonia, can be pneumococcal, then can be any MMR, if you take that, that produces enough interferon 1, and that will produce enough gamma interferons, which will protect you or will make the disease less serious for the next 3 months. That's what the basis is.
Right.
Thank you.
Thank you, sir.
Thank you.
Finally, we just have a comment and a question both together. In fact, this was Dr. Osahon Enabulele. Pardon if I'm pronouncing it wrong.
I think
Who's
KP knows.
President of the Commonwealth Medical Association and coordinator of the Coalition of African National Medical Association. And they wanted to know whether you have any perspective and suggestions on development of vaccines in Africa, sir.
I will not know what is the current situation in Africa because most of the companies, most of the people at this moment, companies are placing orders for the research. So I will not know what is the current situation in Africa. Maybe.
All right. So,
Thank you, sir. Thank you for
The
that,
person who has asked question has some comment to make because mostly people who ask question, they have at least some knowledge. So they may be able to say that.
Yes, we'll just see if
Last-
the person
last-
can come on screen. We'll try and get them on, sir.
okay,
Back to you, Dr. Russell. Yes.
Now, we'll have Dr. Ilana, who is sharing this. Back to you for your comment on your taking it forward. But
Yes,
yeah, go ahead.
Dr. KK Agrawal's lecture was amazing, incredibly comprehensive and very, very clear. And I think it brought us up to speed for